What's up, everybody? Welcome to my cervical spine injuries 101 presentation. Those of you that don't know me, my name is Dr. Matt Maggio. I am the creator of the Peak Method and the founder of the Soft Tissue Revolution, where we teach massage therapists how to make well over $100,000 per year, all by working less than 20 hours per week, by learning to work smarter, not harder. I've been working on these webinars for the past couple of weeks and wanted to share this one specifically going into the components of neck injuries, cervical spine injuries, really show you how my system and my method goes about thinking critically, figuring out the problem and going through that. So I hope you get a lot out of this webinar and go back and watch some of our other ones as well. I make this content just to help people because at the end of the day, I want people to get better access to quality hands-on soft tissue treatment so they can avoid bigger problems like pain pills, injections, and surgeries. In all honesty, stay away from chiropractors and physical therapists, which don't really solve any problems and just make the problem worse. Our job as manual practitioners is get in there, fix it with our hands and do the best that we can. And I want to equip you with the knowledge and the expertise so that you can be confident knowing that not only do you know what the problem is, but you can go in and fix it as well. So let's jump right in. All right. Question I always pose: how can you ever fix a problem if you don't know what it is in the first place? Too much of musculoskeletal care treatment just goes in and it's like, hey, that muscle's tight, it's weak, I got to stretch it, I got to massage it, I got to do that. You don't really know what's really going on. Critical thinking is missing so much in the musculoskeletal world. What you see is that most practitioners diagnose and treat based off what they're trained in instead of what the client actually needs. So chiropractors do adjustments, physical therapists do stretches and exercises, massage therapists do massage work, but we really don't know what's going on. I always give the example of, like, say your car's messed up and you take it to the mechanic and they don't run any diagnostics and they just start treating right away and start hammering on shit. And you're like, hey, why aren't you doing any diagnostics in there? We don't do this in musculoskeletal care. It's like, I do this treatment, you do this treatment. Hey, we can all get along and go from there. But the people that are suffering the most are the clients and the patients because they're not getting a specific idea of what's going on and having you be that true leader and that true solutions provider. So the goal of my method and the Peak Method, number one, is first to just get to a tissue specific problem list. I made a past webinar about that. There's only 7 problems in the human body. When it comes to musculoskeletal injuries, it goes bone, cartilage, disc, ligament, nerve, soft tissue, tendon. I think I got them all. And disc is in there too. I have a whole webinar where I go through that as well. If you're watching this on the YouTube channel, I'll link that up below for that webinar. It's a great one to go in there and just learn to start thinking critically and start figuring out problems, because like I said, you can't fix a problem if you don't know what it is in the first place. Number 2 is we need to restore range of motion. Injuries happen because range of motion is limited. The first step in fixing a problem is we need to restore range of motion. Number 2 is managing their load. When there's an injury, there's this idea of what's called load and capacity. Load is what they do. Capacity is what their muscles can take. When an injury happens, there's more load than capacity. So our job as practitioners is to restore their range of motion, increase their capacity so that they can handle more load. If they're doing way too much load while we're fixing their capacity, it's never going to really be able to solve that problem. I would say it's kind of like treating someone for diabetes and they do really well in the office, but then they go out and eat a shitload of sugar after they're done, and it's not going to get any better. So we have to manage the client's load as well. Then we get into balanced strength. Balanced strength is where we start to build up some of the weakness that forms in there and then put some strength back on it. But we have to get that range of motion first. So much of like physical therapy is going into like balancing strength early in the process instead of actually getting the tissue healthy. We're the first people that people need to see when they're injured. We're like the people that go in and lay the foundation. And the foundation is we must improve the range of motion. If it doesn't move, it must improve. Then we get into increased strength. That's more global movement and things like that. And lastly is we need to maintain that range of motion. I always say when a client first comes into us for an injury and they're having a problem, our first job, and we're like the dentist, we need to go in there and drill out the cavity, get things moving better, feeling better. But once we get in a good place, they need to come in more often for maintenance and stuff like that. So first, get a tissue specific problem list. Number 2, restore range of motion, manage their load, balance strength, increase strength, maintain range of motion. We need to go in this order. What happens in so much musculoskeletal care is people are all over the place. And then it's like building a house and then trying to put the siding and the roof on before you ever lay the foundation. And that's the key, is you have to slow down and figure that problem out. So neck injuries. Whoop. Went too far. So first thing I start to ask is what I call first order history questions. I'm not going to go in depth on here. I have a webinar that I go way more in depth on, and I'll link that up on the YouTube channel. But these are the 7 questions that I must know before I can ever think about treating the patient, touching the patient, or going. It helps me really start thinking critically. Like, first, how old are they? Are they male or female? Where do they feel the pain? What does that pain feel like? Symptom severity. I always like to say, hey, on a scale of 0 to 10, 0, no pain, 10, you wouldn't care if I just cut it off. What's the worst that pain's gotten? When's the last time you had an episode? And what has it been on average over the last 30 days? It really helps me understand if I'm having more of an acute or chronic type of problem. What makes it worse? Like, what type of activities can make it worse? And then what helps it feel better? I want to get this data, and I really go in deep on that other webinar, so I won't exhaust that here. So go through and check that out. Those are my first order history questions. These are the 7 things I must ask and know before ever trying to get to an idea of what I'm going to do for a functional evaluation, what I'm going to do for treatment. Next one is our second order history questions. Have they had any accidents or trauma? Any imaging done, like an X-ray or MRI? What other practitioners have they seen? What did those practitioners tell them was wrong? Did any of those treatments help? Do they like to do any exercising or working out? And what do they do for work? And then my last question is really important. And this is the question everybody misses. How is this problem affecting your quality of life? What happens is we tend to be way too analytical as practitioners and therapists, and we're not actually connecting with them emotionally. Pain and disruption in their life is very emotional. We tend to be more analytical. I really go in depth on that webinar about this, and I would definitely go back and watch that as well. Gives a better context of where we're going. So these are the questions I must ask before I ever go into the idea of critical thinking and figuring out what specific functional test I want to do, and then what palpation, then what treatment. You can see how things start to build up. You're really laying them down in the right order, thinking critically. No one else is doing this. They just want to jump right into treatment. And a lot of therapists be like, well, I just want to get there and feel the tissue, and I can intuitively tell what's going on. And I'm like, bullshit. You don't know. You need to slow down. You really need to be able to figure this out and get to the right tissue specific list so you can fix the problem. First one, bone. Bone is a big factor, especially with age. As people get older, the bone gets more and more deteriorated. You see problems in the joint. And then trauma is also a big factor in there as well. If I have a history of trauma, bone's going to be higher on my list as a potential cervical spine problem. And that bone spurring happens too. What happens over time is when people are putting more force into the bone in the area than it can handle, there's this law called Wolff's Law. And Wolff's Law means the more force you put into something, the more bone it's going to lay down. This accounts for the idea of bone spurring. So what happens over time inside the joints where things come out, the joints start to get these spurring in there, and then they can push down on the nerve and create stenosis, create an entrapment, things like that. And then also the joint capsule itself in the neck, they really get worn down as well. They're really designed to be like more of like a cushion, and a lot of times they get slammed together. So asking yourself those questions, are they older? Definitely bone's going to be a problem. But also trauma. If they had car accidents, if they had falls, if they had sports injuries and things like that, really getting an idea, letting me know that bone could potentially be a problem on my list. Next problem is cartilage. Cartilage isn't going to be a direct problem associated with neck pain because there's not a lot of cartilage in the neck in through the joint as well. There is some inside the cartilage, but that's not as big of a problem. It's going to be more secondary in a shoulder problem. And a lot of times what I find, if someone had an original shoulder injury, a couple of years back, and now it's not moving how it should, the neck might be compensating as well. So that might help you in your history taking and really starting to think critically from where you go. But cartilage will not directly cause neck pain and neck dysfunction. It might be a secondary problem from a shoulder dysfunction. Disc. Disc is what I call the great mimicker of many injuries. Discs are such a problem in our society. We're seeing it so much more. As people get older, like they understand they have disc problems, they get diagnosed with degenerative disc disease. But in all honesty, I am seeing this more and more in my clinics in people in like teenagers, like 16, 17, 18-year-olds, because they spend their whole damn life sitting, looking down on their phone, and it puts a lot of wear and tear into the disc injury itself. And a lot of people look at younger people and they're like, well, you haven't lived long enough to have trauma to the joint, to the disc. But think of like teenagers nowadays. They spent their whole lives living on a phone, looking down. And when they look down and they put themselves in a bad position, it can really mess their neck up and put a lot of pressure on the disc. One of the keys there is symptom location. So one thing that I always kind of break down when I'm having a neck or shoulder problem, I ask, where do you feel the pain? And when people come in and point back here behind the neck into the trap and they say I have a shoulder problem, I say, no, that's a neck problem. And a lot of times a disc problem will really like to go deep inside to the into the rhomboid, into the shoulder blade, really likes to go through there as well. And then sometimes it will get some pain in the front part here, but most discs that I see in like the C6, C7, C5, C6, and C7, C8 tend to really get that pain back here behind the shoulder blade. Symptom quality, you know, they'll describe it as like a sharp, throbbing, deep, achy type of like discomfort where they just don't feel comfortable. And severity, usually what I see with a disc when it's really acute and it really gets banged up, a lot of times it's like a 7, 8, or 9 out of 10. My scale, as I said, in severity is like 0, no pain, 10, you wouldn't care if I cut it off. When a disc is really acute and they flare it up and they get some tearing in there, they're going to be in that 7, 8, or 9 out of 10. Provocative too. A lot of times, like with disc, when you start to move it around, you start to use it, it can flare it up a little bit, or if they've been sitting for a long time or after they're sleeping, the disc can get really inflamed and get beat up, or if they're just stuck in a prolonged position. A lot of times with a palliative part of a disc is once they get up and they start moving, like say they go for a walk, they might do a little bit of stretching, or even if they lay down on it for a little bit, like 5 or 10 minutes, it might relieve that as well. Accidents or trauma. Yeah. Anytime you have like a huge accident or trauma, especially car accidents and stuff like that, it puts a huge force into the disc and can cause some type of disc problem, a bulge, a herniation, or even like an extrusion. And then occupation, like what do they do for work? Are they sitting at their desk all day long for 8 or 9 hours out of the day? Are they stuck in that sedentary posture? That can really give you some ideas too. So I say disc is one of the biggest causes of pain and dysfunction in the cervical spine. It's also missed by so many practitioners because they're not looking at all the data. Ligament. So ligament is definitely very important. What happens over time is there's a ligament that basically runs from the tip of your skull all the way down to the base of your sacrum. I like to break it down into 2 different areas. So basically from the tip of your skull to about C7 is what's called the nuchal ligament. And then after that, from T1 to T6 is called the interspinous ligament. They're basically the same thing, just a little different for orientation and stuff like that. So a big thing on a ligament problem is it's going to be symptom quality. Where, well, I'll go back. Symptom location, like they're going to feel it like directly on the spine, basically from that C1 to T6. And the symptom quality is going to be like a tighter stiffness. Severity for that's going to be like a 3 to 6 out of 10. It's not going to be like a 7, 8, or 9 out of 10, unless it's like an acute accident or trauma. And I usually don't like to mess with those ones because they're too acute and there's a lot of inflammation going on. You know, it's going to be stiff, tough to move, just feels kind of tight. Usually with a ligament issue, the provocative, what makes it worse is as they start to use it, it's going to really start to flare up a little bit. And palliative is just going to be, it feels better when they rest it. That's going to really help me understand there's some ligaments. And then also, was there accidents or trauma in there? A lot of times when there's a lot of accidents and high trauma in there, it can stretch that ligament out, even cause a little bit of tearing. So ligament is definitely a key player in neck problems. Next one is nerve. I say this all the time. There are 256 different places in the human body where a nerve entrapment can occur. And there's a few in the neck that are really important that people miss. So basically, nerve entrapments in a nutshell, basically over time, as the muscle gets more beat up, it doesn't get enough blood flow, it doesn't get enough oxygen, it starts to develop scar tissue. Scar tissue is like glue, gets inside the muscle, makes it harder for the muscle to stretch and contract. I'm going to cover scar tissue on the next slide. But basically over time is that scar tissue gets bigger and bigger and creates like a space occupying lesion. And nerves need to kind of make their way through the body to go where they need to go. And they get stuck inside there. And nerves are built with like 15% of extra slack. So it beats them up a little bit more. So over time, these nerve entrapments occur. And basically where they get the type of problem, you can see that as well, especially in the cervical spine. They might feel like their trap is always tight. They might get some like pain in the anterior part of the neck and even some stuff radiating down in the shoulder blade. And then I also see some stuff like high up in the neck as well. Usually the symptom quality is going to really define that for me. It's going to be numbness, aching, burning, and tension. Provocative, a lot of times when you're having nerve entrapment, it's fine when you're just kind of sitting there, but as soon as you start to use it, it stretches and pulls that nerve and can really give you some pain and increase that numbness, aching, and burning and tension. Palliative just feels better when you don't use it or with rest. So 3 common areas to get nerve entrapments in the neck. One is going to be on the scalenes, specifically at the nerve roots at the scalenes from C5 to T1. The most common area where I see in a nerve entrapment on that is between the middle and the posterior scalene. The other area is going to be at the accessory nerve. That's a really common one. So the accessory nerve comes out behind the ear and then makes its way down, and it controls the SCM in the front and then the trap in the back, and it gets stuck in there. That's actually the most common area where people describe it as like they have a giant knot in their area, in their neck. That's usually an accessory nerve entrapment. And then the last one is just the greater occipital nerve. I see this a lot in the upper suboccipital group, specifically like rectus capitis major and minor, and a little bit of like semispinalis capitis and cervicis, and even a little bit of splenius capitis. The greater occipital nerves can get entrapped up in there. And that can really present with a lot of like your headache and migraine type of clients. But nerve entrapments are definitely a big problem in neck pain, and it's getting overlooked and missed by most practitioners. Soft tissue. Yes, soft tissue is going to be a major factor in any type of cervical spine dysfunction and injury. One's just going to be symptom location, like where do they feel that pain? You're going to feel it a lot like in the neck itself, lateral out through there. Symptom quality, usually with a soft tissue problem, I'm going to see, some tightness, achy, discomfort, sometimes some throbbing. Provocative is just when they use it, it really starts to get beat up, because I say that scar tissue is like glue. Think of it as like taffy that is not moving as much. And then when you start to use it, it really starts to cause some pain in there. And then palliative, sometimes I see it both ways with scar tissue. It does feel a little bit better with motion, but most of the time, once it's done warming up, it feels lousy again. And then you do feel better with a little bit of rest in there. The muscles where I'm going to find the most basic scar tissue accumulation is going to be the muscles in the neck that are responsible for flexion. I see a lot of that in the neck, especially in the posterior part, because we just spend so much of our time sitting and looking down. I also see it in the rotation muscles as well, specifically like in the serratus, the deep cervical muscles like multifidus and rotatory. So I'm going to see a lot of flexion issues in there just because of our postures and our lack of movement and staring at our damn phones all the time. So soft tissue is a big component of neck injuries. Last one is tendon. Tendon, I'm not going to see a problem in the cervical spine. There isn't a lot of tendons in there that are going to cause a lot of dysfunction in there, unless there's like some severe trauma. But most of the time, it's going to be more of a ligament problem that we see. So common diagnoses that I see out there that are completely wrong. Number one is I slept wrong on my neck, AKA torticollis. We get this all the time where the client comes in, they're like, oh, I must have just slept on it wrong. It must be, I just slept on it wrong, and they blame sleep and all that. But what it really is that's actually a very acute disc flare up. What happens over time is when that scar tissue builds up in the muscle, in the nerve, in the ligament, it puts more pressure down on the disc. And the disc is really designed to be a good shock absorber like this. What happens over time is it puts pressure down there. Now it starts to slide and grind on itself. And then you actually get some micro tearing of the disc. It has like a little toothpaste in the middle, and it's surrounded by these rings. And then what happens is that ring rips free, and then they lock up and they can't move their neck. And usually when that happens, they freak the fuck out and they think they just slept on it wrong, and they just need to stretch it. They need to get a deep tissue massage or get an adjustment. No, they need to leave it alone. I talk a lot about these videos as well about like what to do when you have a disc injury, but knowing that it's in there and understanding and communicating effectively to the client about what's going on. Number two is tight traps or that knot in the neck. I already covered that. Most of the time that's an accessory nerve entrapment. The accessory nerve is very superficial and it goes over top. And what happens is people hammer on them like way too much. They go in there really deep, and all they do is kind of stimulate the nerve and piss it off a little bit. It temporarily feels better, but it doesn't actually fix the problem and makes it worse. So understanding that accessory nerve entrapment is really important. And I cover that in my free training. The link to that is in any of the places that you're watching or consuming this content. I go into a real detailed palpation of the cervical spine and understanding where that accessory nerve entrapment is, because so many people are too compressive on it, and what it really needs is proper depth and tension, and people miss out a lot. Last one is upper cross syndrome. I hear this one a lot. In all honesty, anything that has syndrome associated with it is just code word for they don't have a clue of what's going on. And yeah, things are tight, like things are weak, things are stretched, but they don't give us a tissue specific idea of what's going on. So if you're diagnosing your clients with upper cross syndrome, it just really means you don't know what's really going on. You need to know specifically where that problem is, what that problem is. Is it scar tissue? Which muscles does it have scar tissue? Is it a nerve entrapment? Which nerve are entrapped? Is it ligament issues? You need to know these things, because so many people just do what I call like shotgun treatment. They just treat a bunch of shit and see what happens. They don't really know. I want to see what the main problem is. And a lot of times, like I see, it's in those flexion muscles because we do so much. So when you have that scar tissue that builds up, it makes the muscle weaker, less flexible. It doesn't need stretching. It doesn't need strength. It needs range of motion restored, then building the strength, and then building the overall strength. Side note on granny humps. I'm seeing this more and more in our younger youth population. We're going to have an epidemic of neck pain real soon, because these kids have been spending, I sound like these kids, I'm 36, but I haven't spent my whole life on my phone where they have, and their necks are just fucked. Like these kids are just spending their whole life there, and they're starting to get that hump. I found that this really gets the attention of the younger people that are having neck pain. I show them that picture from, like, I'll take a picture from the side and show that. I'll be like, you know what that is? That's a granny hump. And a lot of times they're like, what's that from? It's from scar tissue buildup, bad biomechanics, bad buildup in there, and explaining to them, like, this is going to get worse and this is contributing to this. And where I tend to see the biggest amount of like tissue accumulation is going to be like the C5 to like T1. And then what I find is there's like a huge drop off in the thoracic spine erectors, and those get really beat up and cause that granny hump in there. So the key is always getting to that tissue specific problem list, and then knowing exactly what you can do and what you can fix. So like I said, what are you going to see the most of as soft tissue practitioners? You're going to see scar tissue in the muscles, in the nerves, in the ligaments. You're also going to see a ton of disc degeneration. And that's where that load management comes in, and explaining to the client what they have. You know, so many people are just walking around without a true diagnosis of what's going on. And then they go and do a bunch of stupid shit, and they can't figure out why their problem isn't getting any better. No one's giving them real answers about what's going on. Like, saying words with like syndrome or tight or weak or not firing is bullshit. It doesn't really tell you anything. You need to have a tissue specific problem list of what's going on. So how does my method go about treating this? First is we need to start by evaluating global motion first. I start in the cervical spine by evaluating flexion first, then rotation, and we need to restore a range of motion back. And then we start with manual/instrument based scar tissue treatments to restore range of motion by directly treating the muscles, nerves, and ligaments. Then we manage the load of the disc, sometimes in the bone. We don't directly treat the disc, we don't directly treat the bone, and a lot of times we don't directly treat the cartilage or tendon, but we manage that load. Think of those like the bone, the cartilage, and the disc as your thumb stuck inside a car door. The car door is all the scar tissue. We can't give the thumb a chance to heal up until we remove that. That's what we do. Then I manage their load with what I call a postural transformation program, just basic shit like getting people to take a walk in the morning, drinking water, watching their posture on their phone, doing a 10-minute lay down at the end of the day, because that's the problem. And why a lot of treatments don't work for people is because you're doing a bunch of stuff and they're not following through and doing their part at home. It's that diabetes analogy I gave earlier. Then I give them some corrective exercises to the deep neck flexors as well in the anterior part of the spine. I say your neck is just like your lumbar, and your lower body has a cord just like that. And these muscles get really weak and don't function properly because they're just constantly in that shortened position. So once we restore as much range of motion as possible, then I give an exercise to go in there and strengthen those muscles, but not until I fix as much movement, inflection, and rotation as possible. Then lastly, we just get them to breathe better. Breathing is really important. teaching them how to belly breathe, diaphragm breathing, getting them to not breathe with their scalenes and their deep neck flexors and stuff like that. But they all have to kind of go in order. Like I said, the first step is restoring range. That's laying the foundation. Then we put the siding on, then we put the roof on. And what happens is so many people start with the siding and the roof and they're not getting there. And if you don't have a foundation, it's just going to fall apart. So that's how my method, the peak method, goes about treating cervical spine injuries. So that's all I got. Thank you so much for watching. If you have any questions, leave them below and comment, and I'll be sure to answer each one. Next is just get access to our free training at the website listed below. It really goes in deep on cervical spine, shoulder, thoracic spine, lumbar, and hip, and you really get an idea of like how I evaluate things, identifying the types of pathologies, critical thinking, and really get you off the path of being a service provider to becoming more of a solution provider. And lastly, just reach out if you have any topics or questions that you might want us to cover. I'm going to be doing these webinars over the next couple of weeks and sharing them on the YouTube channel. So subscribe, share them with other people. Join me on my journey to really help people get quality access to soft tissue treatment that they truly need so they can avoid bigger problems like pain pills, injections, and surgeries, which only make things worse. I appreciate you guys watching, and I'll see you guys on the next one.